So, dear colleagues, dear friends, 大家好. With this, my Chinese is finished. So I want to say thanks to Dr. Zhao Haimin for this invitation. Every year he makes this invitation for me, and I know him for 6 years now. This is my 6th year. It should be the last, depending on him. Perhaps I stay more, but we don't know. Okay, so let me. So the title of my presentation, I will try to speak a little bit slowly, so perhaps you can follow. My is an English Italian, so English is already difficult. Plus, my dialect is even worse. Anyway, so the title of my presentation is the application of hysteroscopy in repeated abortion. So you know me, I work at Rangi Hospital as leader of the Sino-European Life Expert Center. And this center is the first unit dedicated to hysteroscopy ever made. There is a similar one in Rome. So the Western, the Italian, copy the Chinese, not the opposite. So this is very important. For the first time, the other people are copying you. It's not the opposite. Normally, we say that the Chinese, they copy, no? But this is, the center of Shanghai is unique. There is no other center in the world like this one, especially for the number. So everything I will say today is included in the Rangi Hospital guidelines, which are the guidelines we follow in our center. We are 3 doctors, and each one of us follow the same rules. So it's not possible that somebody does something different from the other. We try to standardize our technique. And so you can ask for this book by Bioregion. Bioregion is a company making a gel for adhesion prevention. And you can ask the company to give you the book. There is a Chinese and an English version. Okay, so these are the guidelines. I made this book together with Dr. Rudy Campo from Belgium. So to go back to the topic of my lecture, the incidence in the general population of uterine malformation, which are related to miscarriage, is 6.7%. Of course, in the infertile population, this percentage is increased to 7.3. In recurrent miscarriage, the uterine malformation have an incidence of about 20%, 16.7%. And this is understandable, no? So what is interesting in uterine malformation is the classification which was made recently by a group. It was a consensus between ESHRE and HGE on classification of the female genital tract. So Professor Greenbees from Thessaloniki, Greece. He was in charge of this group, and they came out with this classification after many years. What is the importance of this classification? There are 2 things. The first thing is that define for the first time a normal uterus. So what is normal and what is congenital. And second is the introduction of a new class of malformation, which is dysmorphic uterus, which you should not confuse with synechia or adhesions. These are malformation. You are born like this, okay? So normal uterus. The normal uterus should have the shape of the martini glass. You know the martini glass? The cocktail by James Bond. You know, it's like a real glass of martini, the cocktail. And the interostitial space that you can see here, no, can be flat or can have an indentation. So something coming in the cavity. This indentation should not exceed 50% of the uterine wall thickness. So sometimes we think that this is a partial septum, but according to this new classification, is not a septum, but is a normal cavity, and which should not be treated, because a normal cavity you can have a normal delivery, no miscarriage, no? If you have repeated miscarriage, of course, you can do some treatment. But this is important to define what is normal compared to what is abnormal. And what is abnormal is dysmorphic uterus, the first class, which is class U1. There are two kinds of dysmorphic uterus. There is a T-shaped uterus and a uterus infantilis. What is the characteristic of this malformation? Is the lateral wall of the cavity, which are thick. And so if let's say the corpus is 2/3 and the cervix is only 1/3, you have this T-shaped uterus, is like a T. No, you can see very well. And what you have to correct in this case, which is very clear here, I show you directly. Enlarge the volume of the cavity. So you have to cut the lateral wall and also the fundus to make it bigger. And another class U1, U1B, is the uterus infantilis. The difference is only the cervical part compared to the corpus. You see that the cervix is 2/3 and the corpus is small. But always it's like a T. The cavity is like a T. So if you want to enlarge this cavity, you have to cut the lateral wall and the fundus. You can see that in the fundus there is an indentation, no? So this is not a septum, but this is a dysmorphic uterus, because the indentation is not so much to justify a class U2, a septum. What is the reason why we should start thinking to treat dysmorphic uterus correction? There are actually two studies, one by Jaime Ferro, he works in Valencia, in the EV Center of Valencia, one of the biggest IVF center in the world. And he treated 190 cases. The other one is in Italian, Attilio Di Spezio, in 2019. You see that if you do the correction, the pregnancy rate is about 80% in case of Jaime. Jaime was the one who introduced the correct technique how to treat the dysmorphic uterus. Attilio Di Spezio, a little bit less, 72.9%. The abortion rate, the miscarriage rate, is only 10% in case of Jaime and 20% in case of Attilio. So if you do the correction, you have a better pregnancy rate and you reduce the miscarriage rate. So this is the reason why we should think about treating these patients. What we want to do in Renji Hospital, because the numbers are much bigger. So we do about from 30 to 40 cases per month of dysmorphic uterus correction. So you can imagine the number are much bigger than these numbers. So what we would like to do in the future, together with Zhao, to make a study and to see, best would be to do something like this. The limitations of this treatment are that all the studies I showed to you before are retrospective. So they do the treatment, they wait, and they call the patient. So this is a retrospective cohort studies. And some are in one center, some are multi-center, but all retrospective, and this is a big limit. The second is that are all observational study. So there is not an untreated control group to compare. There are no randomized control study, both on dysmorphic uterus and on septum. So this is a big limit of this kind of treatment. You don't know if you treat these patients, if your success is due to your treatment or not. If you didn't do anything, perhaps you have the same result. So this is why randomized control studies are important in case of septum and uterus and dysmorphic uterus. Another thing we don't know if is the cutting of the lateral wall and the fundus, so the fact that you enlarge the uterine volume, or is the scratching that you do that improve the fertility. And therefore, we think that the shaver is much better because what they do in Europe, they just cut with the scissor. In Rangy Hospital, we cut and then we use the shaver. So we scratched all the surface of the endometrium. So if these patients go to IVF, the result is even better than the one that I showed you before by these two colleagues in Europe because of this scratching that we do. But we don't know which is the reason. Is because we enlarge, we make the cavity bigger, or just because we scratch the endometrium? This is something which has no answer yet. So let's go to the class U2. Class U2, you have a partial septate uterus, and class U2A. U2B is complete septate uterus. And this depends on the indentation. If the uterine indentation exceeds 50% of the uterus wall, corpus wall, but that is below the what is called the inner cervical os, then is a partial septate uterus. If this indentation reaches or is over the inner cervical os, is U2B. It's very simple. It depends on the indentation. You see that most of the partial septum are in real normal cavity. So you should see, and the diagnosis should be made by ultrasound, not by hysteroscopy. This is U2B, is a complete septate uterus. So which is the strategy we use at Rangy Hospital when we find a septum? The diagnosis should be made by 3D ultrasound. If you make the diagnosis by 3D ultrasound, you know exactly if the fundus is a single or if you have a class U3. So these two separate uterus, a didelphus uterus. So this is important because didelphus uterus doesn't need any correction. If the fundus is not single, you cannot correct by hysteroscopy. Then we confirm the diagnosis by, in the past, we were doing laparoscopy to confirm the fact that you had a septum and not a didelphus. Now today with 3D ultrasound, we bypassed and there is no need of laparoscopy anymore. Then we always do diagnostic hysteroscopy with the trophyscope without any kind of anesthesia. And then we plan operative hysteroscopy. You have three possibilities. You can cut the septum with the trophyscope. The trophyscope, the scissors are very tiny, only a few millimeters. It's very difficult. It's very painful because the patient is awake and the visibility is not so good. You can use the shaver. We think that the mechanical energy is much better than electricity. In China, we can only use the big shaver, the 24 French, which is 8 millimeter. But in future, you will be able to use the 19 or even the 15 French shaver, only 5 millimeter. The technique, we combine the technique, scissor and shaver. So we use both. And we believe that this is much better because mechanical energy is better for infertility for many reasons. Or you can use the receptoscope according to what you have. You can use the 26, the 22, or the 15. In the past, I always used the 26 because in Italy I only had the 26. Now you can use the 15. It's much better. After 3 months, you look to the patient again with the trophyscope, and if there is a recurrence, then you can cut with the trophyscope. The reason why we think that the shaver is good is not only because it's a mechanical energy, but because you remove the fibrosis by using the shaver. You not only limit yourself to cut, but you also remove the portion of septum left with the shaver. Now people who are using the receptoscope, they don't limit themselves only to cut the septum, but they use the loop to remove the remaining portion of the septum, to reduce the recurrence rate of septum. Anyway, I still think that mechanical energy, because you are not eating inside the uterine cavity, is much better for infertility. This is the task, no? We want to cut the septum for which reason? Because the patient has to reduce the number of miscarriages after 2 miscarriages, and we want the patient to conceive in short time. So we don't want to have a recurrence of the septum. So that's why we think that the shaver is better than operative. This is the campotrophiscope. The advantage of this instrument is that the optics is very tiny, only 2.9 millimeter. When you push the operative channel in, it goes up to 4.4 millimeter, which is very good. It's less than 15 French, it's less than 5 millimeter. But as I told you before, it's very difficult, it is painful, you need to have some kind of anesthesia if you want to do the treatment of a septum with the campotrophiscope. Then you have the reusable Pigati shaver, this guy in the middle, you know, and there are 3 sizes, the 8 millimeter, the 6 millimeter, and the 5 millimeter, which are not available in China. The 8 millimeter and the 6 millimeter use the same blade, 4.5 millimeter blade. The 5 millimeter is only very tiny and use a blade of 3.5 millimeters, smaller blade. So you can do the majority of soft tissue. You cannot do approach myomas with this blade. But anyway, this is another topic. Then in China, you have many companies which are coming out with reusable shaver. This is INSEE or IGMED, and it's very good because the scope is only 22 French, which is smaller than the 24 French I use at Rangi Hospital. It's 7 millimeter, a little bit less than my shaver, the optical system, I mean. And the quality is good. Then there is also KMS, another company, who is coming out with a reusable shaver. So in China now you have a really a large possibility to get shaver at let's say at cheaper price, because I know that one of the biggest problem of the Pigati shaver was the initial cost. Even if I think that the initial cost is a problem, but if you do so many procedure after a while, you know, you absorb this high cost that you have at the beginning. The past for me is the receptoscope. The receptoscope is the past because you have a low visibility. You need a long time to learn how to use the receptoscope. It's using electricity, which is not good for infertility, and you have a very high complication rate because of the visibility, which is reduced by the use of the loop of the receptoscope. The perforation rate is high, is dangerous, and because you are using electricity. And of course, you can have a fluid overload, especially when you treat large myomas. And also, the biggest problem of receptoscope is gas embolism. It's not perforation. Perforation you can have also with the shaver. A fluid overload you can have also with the shaver, but gas embolism you cannot have with mechanical energy. And if you have a gas embolism with receptoscope, is really a big, big problem. You might lose your patient just for a myoma or a small polyp. So, and this is the treatment of T-shaped uterus. We call this treatment T-shape like treatment because at Rangi, you see, this is a uterus infantilis, like I showed you before. This is the 3D ultrasound we did at Rangi Hospital. So the beauty of this technique, if you use the shaver at the beginning, you clean your view, so the cutting become easy. And also because you are using big scissor and not tiny scissor, it's very, very easy to cut the lateral wall. Another thing you have to learn by doing this is that the cutting should be made at 3 o'clock and 9 o'clock. This is the only, let's say, details you should follow. And to do this, you have to be able to rotate the optics, because the optics is a 90-degree optic. If you just rotate, you see, this is cutting to the fundus, it's very easy, no problem. But if you want to cut the left side, you have to rotate the optics by 90 degrees at 3 o'clock, like you will see now. The rotation will be from here to here. You have to cut here and here. Because doing this, you enlarge the uterine volume and you cut the thick wall, the thick lateral wall, which you see the rotation of 90 degrees, 3 o'clock. And this is important. If you don't rotate the optic and you keep this position, it will be very difficult to cut. Just lift your hand like this, and it's like that. A kid can do it, believe me. More difficult to cut to the right side, because the right side you can go from the top or from below. From below you have to push up to cut at 9 o'clock. Oh, what's wrong? Sorry, I don't know. Oh. Let me go back again, sorry. I think this is the final image. And after that you cut, you use the shaver again. So you remove the fibrosis that you have been cutting. When you use the shaver again, you should be able to reduce the aspiration, because when you activate the shaver, you have an aspiration on the tip. So if you keep the aspiration that we normally use of 250 milliliters per minute, the bleeding will increase. So this is a trick. You should reduce this aspiration again so you see well. But here you have to cut here, here, and the fundus. And this is the final image. You see here, this part and this part. Most of the people who come at Rangi Hospital, actually, they don't have a real T-shaped uterus. They have like a normal cavity, but perhaps they had 2-3 miscarriage. So we do this treatment, even if we don't have the ultrasound who testify that this is a T-shaped uterus, because we have seen that by doing this, we increase the pregnancy rate of the patients. So people come to Rangi Hospital because they know that after this treatment, they can achieve a pregnancy faster. This is something we cannot explain, but this is real. Allora, this is a partial septate uterus. You will see that you can use the receptoscope, you can use the trophy, as I said to you before, but we combine the technique scissor and shaver. I prefer to use blunt scissor because blunt scissor are safer, and you always have to keep an eye on the tubal ostia. When you reach the level of the tubal ostia, you stop. This technique is also very simple, and we use the shaver after cutting because we want to remove the fibrosis which is left on the top, on the anterior and the posterior wall. If you do this, the recurrence rate in case of septum is very, very little, especially in the complete septum. I will show you the next case is even better. You can use the bipolar probe in case of bleeding, but most of the time it's not necessary. Not necessary. The beauty of this technique is that you always see what you do. The time is almost the same as using the receptoscope, but of course when you use electricity, when you use the hook, is more dangerous than using the scissor. I mean, the risk of perforation. The time is almost the same, and the risk of perforation is less in case of when you use scissor. This is especially when you use blunt scissor. Okay, this is the last video. This was done at the beginning of my presence here in Shanghai, I mean 5 years ago. So we were still doing, we didn't have the 3D ultrasound, so we were still doing laparoscopy. So this is a complete septum. You see that the indentation reaches the inner cervical os. This is a large interosteal diameter. We are on the right side of the two cavities. We use the shaver to reduce all this overgrowth so that we see better. And you will see by transient illumination that we are in the right place. This is a trick. By laparoscopy, you switch off all the lights, and you will exactly see that we are on the right side. This is a trick we used to have in the past when we didn't have the 3D ultrasound. You see, you switch off the light, and you will see that we are here on the right side. So here we put the shaver. We clean all the endometrium. And then by coming out, we couldn't find before with diagnostic hysteroscopy the entrance to the other cavity. By using the shaver, we found the entrance to the other cavity. This is a complete septum. Another trick you have to use when you use the shaver and you use the scissor, you have to change the rubber cap. There is a cap on the operative channel, and the shaver is bigger. The scissors are a little bit smaller, so you should have a cap which is smaller. In this case, we didn't have this rubber cap. I'm talking about 5 years ago. So you will see that when I put the scissor, the uterus tends to collapse because we lose water from the operative channel. So the alternative, when you have this, you have to go very close to the tissue you want to cut. See, it's not very clean because we lost intrauterine pressure. So I go closer with the optic and I can see the place where I have to cut. Always blunt scissor. For me, blunt scissors are better, a little bit slower than the sharp scissor, but safer. And you always have to look to the tubal ostia, no? The two tubal ostia. As the cavity distends, the visibility improves. This part of the septum, the upper part and the lower part, has to be removed. So we do some coagulation first, and then we put the shaver again, and we remove the fibrosis which is left. If you do this, the recurrence rate of septum is very little. This part and this part has to be removed, this and this. You can see how thin is the wall by transillumination. You could see before, It's a big septum. This part has already been removed with the shaver. When you do this, you have to reduce the speed of the shaver. These are all small tricks which come with experience. No? These are the two tubal ostia, just to see that we cut at the level of the tubal ostia. Okay, this is the work made at Rangi Hospital. These are the first 4 years that I work at Rangi Hospital. You see the total number is very big, it's 15,675 procedure between diagnostic and operative. The number of operative per year, the number of trophy scope, purely diagnostic, is about the same. The operative with shaver and a small amount of trophy, it's increasing, and also the total number of procedure is increasing. The database, which includes all the cases I've been doing with the shaver since I started in 2009 until last year, September 2023, was about 7,000 procedure. Now we are more than 10,000 procedure with the shaver. I'm revising a little bit this number because it's not completely precise, as in some cases let's say the doctor was in charge to collect the database, mix some small operation with the trophy with the shaver. So it could be that the number is a little bit less, but it will be always around more than 9,000 procedures made with the shaver. which is the biggest database you can find in literature regarding the shaver, thanks to the work made by us at Renji Hospital, thanks to China, actually, thanks to China. Okay, you see the number of operative procedures made with the shaver are mainly polyps and soft tissue. They are about 80% of the work. Then you have about 8 to 10% of myomas, which are successfully made with the shaver. I'm talking about success, not about failure. And then you have about 7 to 8% of other indication, and about 5% of T-shape like uterus correction. This 5% could be a little bit overestimated also for the problems I told you before, because you should not confuse what is a T-shaped uterus with a synechia. These are synechia or adhesions are made by us in most of the cases or by infection. So they are post-operative complication. A T-shaped uterus is a uterine malformation. So you are born with a T-shaped uterus. Okay, this is important. Don't confuse the two things. If you confuse the two things, the number of T-shaped uterus-like is too much. Okay, this is my last slide. The advantages of the shaver is the learning curve is very short. You have much better visibility. You are much faster in most of the cases. You have a low complication rate. You can have complication also with the shaver, but the complications are less and less severe. And the cost also is a big advantage because apart from the Chinese shaver, which are much cheaper than the Pigati shaver, according to the number of procedures, you save a lot of money. And the only limit are large myomas. As I said to you before, we approach about 8 to 10% of myomas. We cannot approach myomas which are bigger than 4 centimeters. But if you stay, the indication is between 3 and 4. Most of the cases you succeed also to remove myomas with the shaver. Totally different technique. Time is not in terms of seconds by minutes, but it's okay. You can do it. 20 minutes, 25 minutes is okay. So thanks very much for your attention. And if you want to connect to my WeChat, feel free to scan the QR code. Thanks a lot for your attention.
刚才那个比盖蒂教授给我们详细讲解他的一个咆哮系统在这个宫腔疾病当中的一个治